All right, everybody, we are recording. Mike, if you would like to take over and share your screen, that would be wonderful.
Okay, working on that.
I'm going to stop my sharing. Mike, I see it and it looks tremendous. So hold on for just a moment. We'll pause and I will introduce you. Welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Our topic today is managing glaucoma with OCT imaging, and we're very fortunate to have as our speaker tonight, Dr. Michael Shiglazian. Dr. Shiglazian is Associate Professor at the Illinois College of Optometry and Chief of Staff of the Illinois Eye Institute. He's a graduate of SUNY New York College of Optometry, and he completed a residency in primary care ocular disease at the Pennsylvania College of Optometry, where he and I actually first met. He is a founding member, immediate past president, and currently the executive vice president of the Optometric Glaucoma Society. I can tell you that the society thrived under his leadership. His clinical practice is focused exclusively on patients with glaucoma and related conditions, while he also manages surgical care as well, co-manages surgical care. His research interests include perimetry and OCT technology, particularly in the collection of reference databases. Now, on a personal note, I've always said and always have known that Dr. Mike Shiglazian is really one of the true gentlemen of the profession. He is an inspirational educator, clinician. He has done untold amounts for the profession. He has shown good glaucoma leadership to optometry, and we owe him really a debt of gratitude. So with that, please give a nice virtual round of applause and welcome our speaker and my close personal friend, Dr. Michael Shiglazian. Mike, take it away.
Joe, thank you so much. Those are extremely kind words, and I could certainly say all the same things about you. It's great to have long-term friendships and relationships in this profession, and what makes doing this education so fun. And so it's really a pleasure to be back with the OEC group and all the fine administrators and with your audience as well. I think we had a great meeting back in October. I talked, of course, about a lot of glaucoma stuff because that's what I live and breathe. And we didn't really get to spend enough time on OCT imaging and the use of OCT in managing glaucoma patients. So you were kind enough to invite me back here. And so I put together a new lecture and look forward to an engaging evening with everyone as we take a deeper dive into the use of the OCT in managing our glaucoma patients. And, I saw the poll. I think that's, great that well over 50% of the optometrists here have an OCT in the office, but there's still lots to learn here for those of you who might not have immediate access to an OCT. There's lots of general principles. Perhaps you're working with someone or referring your patients out for OCT. So I'll keep it very broad-based, and we're here this evening to just have everyone be more comfortable with their glaucoma patients. That's what I've been doing for 30 years. I know, Joe, you've been doing a lot of that with glaucoma and neurodisease and many other things as well. So again, thanks everyone. Here are my disclosures. So let's start off by just, why OCT? I mean, it's, relatively obvious in 2021 why OCT is such a critical part of the diagnosis and ongoing management of patients with glaucoma. But what I want to take you through here this evening is to really understand the best practices and the best tips that I can provide for you so that using the technology in your office as directed for glaucoma patients and glaucoma suspects is really an expert tool in your expert hands. Because OCTs can be misleading, they can provide erroneous data and information. Sometimes we forget that, they are not perfect. We may even forget what they're looking for. Are they looking at just the retinal nerve fiber layer? Are they looking at the optic disc size, the cup size, the neuroretinal rim? I mean, there's a whole host of parameters and metrics that we get from our OCT reports. Certainly, we know that OCT is just part of the diagnosis paradigm for glaucoma patients, and we'll continue to reinforce that tonight because we understand that while OCT is very important, it's not the only thing that we need to identify glaucoma in our patients. And a lot of what we'll be talking about tonight is represented by that diagram on the left, which is what we refer to as the structure and function. The function of the visual field and the visual system as depicted by our visual field testing, along with the structural assessment of the optic nerve, retinal nerve fiber layer, and ganglion cell layer in the macula. It's about putting all those things together so that we can make the right and best diagnosis for your patients. So one thing I just thought I'd throw out there first, which is surprisingly still a little bit of a question that I think almost all of us know if we ask this in the form of a test question or a multiple choice question that we often do, because we're so familiar with OCTs and their capabilities over the past 25 years that we know that OCTs can pick up glaucoma before visual fields. And yet there's still some misconception or doubt or hesitation on the part of optometrists and ophthalmologists, sometimes in my experience, for needing to have a visual field defect in order to begin therapy. Well, I just wanted to, again, put this out there that this is not the case, and I'm going to show you some evidence why that is in just a couple of slides, and that, OCTs really do lead the way for us in making a diagnosis, but they are not the only thing. We should never really use them alone. I'm encouraging everyone on the call here to make sure that you're using your OCT in conjunction with your threshold visual fields. Disc photographs are also essential. And of course, then your OCT either in the office or if you're ordering it for a patient who may be consulting with someone outside the office. But visual fields are a defined standard of care. We need them even if they're normal, and you can still diagnose your patient with glaucoma with a normal visual field, and I'll show you that in a couple of minutes. And we need them down the road. So if you're managing glaucoma patients, you need a baseline of several fields up front in order to manage this disease in the middle to late stages before you might be sending it out for a surgical procedure, a laser procedure, or something like that. Disc photographs also, OCTs are not a replacement for disc photographs. Disc hemorrhages, peripapillary atrophy are not seen on the OCT. You really need some type of good quality digital photograph. And then to reiterate, the OCT is used in conjunction with all the other risk factors that we discussed in our earlier lecture for glaucoma. IOP, CCT is central corneal thickness or your pachymetry findings. You may be doing corneal hysteresis. It's not a requirement. We talked about that as a risk factor. Age, race, et cetera, all those other things, of course, are what we look at. So let's think about this question of, why, we recognize and understand that OCT can identify glaucoma before we see a field defect, and therefore we don't have to wait for it. In this early study, the investigators found that an average of 28% of the retinal ganglion cells, so think of retinal ganglion cells and retinal ganglion cell axons. This is what we're measuring the thickness of or obtaining imaging of with our OCT devices. It's one of the critical aspects of this disease and the pathology of glaucoma. So average loss of 28% of them before a first field defect, with a range of 6 to 57%. So obviously you want to get ahead of the curve for your patients with glaucoma, and that's what an OCT can provide. Here's another investigation that we look at a lot, and this is called the tipping point. Here, if you read the graph from the upper right corner down to the lower left, this is the threshold in decibels for your visual field defect, from a normal visual field at 0 to -5 dBs to a very serious and significant field defect at -10 to the average thickness of the retinal nerve fiber layer in microns. And you can see here, once you get down to 75 microns, this is the tipping point when field defects really begin to start to appear. Now, sometimes they appear earlier, but they're smaller, more elusive. They can be variable. You might not detect them on a 24-2 grid. So keep those things in mind. And as you're tracking your patients, and we'll see examples of this in my slides, many of your patients start off up here, of course, with a normal average retinal nerve fiber layer thickness, and then get down to 75, and then the field loss starts to come very quickly. So another study looked at, how much time do we gain by doing OCTs and identifying glaucoma prior to visual fields. And in this study, it was identified that, again, field defects start to show up at 75 microns in glaucomatous eyes versus 90 microns of average RNFL thickness in normals and controls. And so that's, again, gives you this reference range. And I'm going to spend a little bit of time this evening talking about the reference database and the difference between green disease and red disease, and a little bit of where the floor is for our OCT devices. All of these are important concepts as you are reviewing the reports and analyses from your OCT devices so that you are making the best and most accurate diagnosis of glaucoma. And here's just an example of a case where the OCT device back here, and we're going to take a deep dive and look at the thickness map and the deviation map that is shown here from this OCT device, showing you superior temporal retinal nerve fiber layer loss. Very clear. Actually doesn't change too much over the 4 years during this time period, but the field is normal. The field is normal, normal again, really normal again, and maybe just starting to show a defect here 4 to 5 years later. And then the field defect starts to progress even more quickly after that. And that could be even with treatment and intervention, because, well, you may lower the pressure at this point here after if you waited to make a diagnosis of glaucoma based on a field defect. If you waited that 4 years, again, that would be incorrect. But the damage that's built up during those preceding 4 years can continue on even after you've lowered the intraocular pressure because of damage that takes place within the optic nerve and the retinal ganglion cell axons.
Mike, before you move on, I think there's what catches my eye. I think this is really interesting here is you point out in the deviation map how there really hasn't been much change. But I'm a caveman. I like looking at the pictures on the wall. And I look at the thickness map 2008 and 2012. If I just go back and forth between those two, even on the thickness map, at least we can probably look at it and say clinically, that looks kind of suspicious.
Yeah, absolutely. And I've got some good examples of that coming up, Joe. So point that out again. As I'm talking over a slide and I can't think of everything to say. So feel free to jump in anytime and point out those key things. Just as you say here, look at the thickness here, the red regions at the 12 o'clock and 6 o'clock area. Those are virtually absent here in 2012 and start to disappear here pretty easily and noticeably in 2010 and certainly in 2011. So that will be exactly one of my points in the slides coming up, that you have to use all of the displays and plots on your OCT report in order to make an accurate diagnosis. And I'll just jump back or maybe step aside here for a second to reiterate that in terms of visual field loss in glaucoma, about 10 years ago now, the American Glaucoma Society redefine the ICD-10 staging system for severity of glaucoma disease. And so this is generally what we should be abiding by as we are making a diagnosis of glaucoma. And they defined mild stage glaucoma as having a normal visual field. So yes, you can diagnose your glaucoma patient without a field defect. Again, I know that perhaps I'm reiterating that too much, and that sounds very obvious to everyone. And yet it's still surprising when I talk to optometrists who are referring patients in like, well, I wasn't sure what to do because there isn't a field defect. Well, again, that fields into, two things. A, the OCT is wrong and it's not glaucoma, or its OCT is correct and it's just way ahead of the visual field. So keep that in mind as you move through these severity stages for glaucoma based on the AGS system. So let's just, again, let's take a 30,000 foot view of what's going on with our OCT device. We're trying to scan and image the posterior pole, optic nerve, and macular region for our glaucoma patients. We scan in a variety of ways depending on the device around the optic disc, maybe in a cube of data, maybe a circle scan. We get what's called the circumpapillary retinal nerve fiber layer thickness map. We may do that in a cube, also collecting all data in a square around the optic disc and retinal nerve fiber layer. We may also get some optic disc parameters. So we may want to know the disc size, the cup size. We may want to know information about the neuroretinal rim. That comes from scanning the optic disc and the RPE tips underneath the surface of the retina. We'll also scan in the macular region because everyone knows by now that we want information about the ganglion cells. And there's different ways to do that within the macular region. And then newer ways and other instruments are now putting this all together and taking a single scan for us, a much larger scan, much faster. And it's a large green rectangle here that gets all this information at once. So that's where we're looking in the back of the eye. Of course, all of that is related to the anatomy. So keep in mind that, just look at the line diagram for this black and white line diagram for the right eye on the left side here. And I've outlined in red, the retinal nerve fiber layer bundle for the superior region, for the inferior region, sort of a square around the macular region, our circumpapillary RNFL thickness map in the blue circle, and then our disc margin outline as well. And then keep in mind, all of this is translating into what the OCT must do, which is identify the ganglion cell layer, the retinal nerve fiber layer. Sometimes it's a ganglion cell layer plus the interplexiform layer. So that's what you're asking your OCT device to do for you, because this is the level at which glaucoma damage is taking place in our patients. It's showing up in the retina and the retinal nerve fiber layer in both the optic disc region and in the macular region. To reiterate for everyone, and just to, again, set a foundation, this classic structure function diagram lets us know what we're looking for when we are evaluating our glaucoma patients. And so as much as I'm going to take a deep dive in the next several slides on OCT only, it's always about looking in the back of the eye at a photograph typically and looking at the neuroretinal rim, disc margin, notching to the neuroretinal rim, looking at the retinal nerve fiber layer on a color photograph or ophthalmoscopic view if you can see it. Doing a visual field test and looking for, small isolated defects that may show up in the central portion of vision that some glaucoma patients present with. It's not all about peripheral or edge defects or nasal steps or arcuate scotomas. Looking at the thickness map for the retinal nerve fiber layer, there's a great example in the lower left for a inferior temporal bundle defect. That dark blue area shows where the thinning to the retinal nerve fiber layer is, and it's in that very classical pattern that we see. There's a quadrant plot that identifies an area of abnormality compared to the reference database. And then in the D block is the ganglion cell scan. And so here we have the loss of ganglion cells and interplexiform layer, to be more technical on this instrument. And it correlates to the loss inferiorly that we were seeing with the RNFL. And we'll talk more about that in a couple of slides. So putting all of that together and looking at your OCT report requires many things. First, of course, it requires a quality scan so that you are analyzing accurate and valid information. And so not having a good quality scan, having somebody who is moving, not centered on the image, a poor tear film, a very dense cataract, perhaps they should have been dilated in order to get a better signal strength. All of those things come in and start causing artifacts and masqueraders and things like that. So we're going to spend a whole section on that later on in this evening's presentation to talk about some of the artifacts and more importantly on the masqueraders and confounders of non-glaucomatous conditions that can really fool us and trick us into thinking that our patient might have glaucoma when really it's some other form of retinal disease or optic neuropathy. So the next part is to just mention and reference that we all have, of the 67% of us that have OCT devices, we have 3 or 4 of the major different manufacturers of OCT devices, and we don't all have the same. And even if we have the same device, we may be using different summary reports from the same device. So this is really a very messy area, if you ask me, and our manufacturers have not guided us very well. They've not identified enough commonality and agreement and consensus between what should be on a report. And the manufacturers, I guess, to their acknowledgement, they are trying to do better than the other company, and so they're trying to display the information for you in as easy a way to read as possible. Oh my gosh, sorry, was silence, but family members can get through on my silence. So we're all looking at different summary reports. And it's important to really understand the report. And so I'm going to take you through with one device here this evening for the majority of the work, just to show you what I think is sort of the best representation of the different components of a report. But I'm really trying to speak to all devices in different reports and get all of the practitioners on the call tonight to understand what to look for and how to use these complex, multi-layered, multi-plotted reports with a whole bunch of information to make an accurate and efficient assessment of what's going on with their glaucoma, with their patient, and identify whether or not glaucoma is present. So we'll start here with a report from the Cirrus device. It's pretty, one of the more popular ones, if you will, although again, I'm not saying that the Cirrus is better or worse than anything else. I'm just using it as an example this evening. I want you to try to, draw back to your own OCT device and see what reports you're using, see how recently you've updated the software. And that's another hindrance, I guess I should mention, why the devices differ so much, is that many parts of this report, if not all of them, require FDA approval. And so submitting the data to the FDA and getting it approved to present to a practitioner is a hurdle that some companies choose to pursue in different degrees and with different intensities and dedications, if you will. So in terms of reading this printout, again, first make sure that you have a quality report. No sense reading a bad photograph or a bad OCT image. And if you didn't get a good image, go back and try and do it again. Again, tips: dilate the patient, artificial tears, steady fixation, retrain your technician, have the company come in and retrain the technician, whatever you can do to get a good quality report. Otherwise, you're just going to be horribly misled on a lot of reports. The next thing to do is to work towards getting all the information in front of you on a display, on a monitor that you possibly can. Hopefully many of us, all of us are probably working in some sort of electronic health record environment. Sometimes electronic health records do a decent job of showing us our OCT reports and images and visual fields. Sometimes they don't. But here again, if you can't see the data, if you can't read it, if you can't line it up, if you can't flip back and forth between the OCT, the visual field, the optic disc photograph, you're putting yourself at a disadvantage. Even before we get into the mechanics of, dissecting an OCT report, you need to be able to see the information. So again, my recommendation is examine your workflow in your office and know that, I can't analyze an OCT report without having the RNFL and optic disc on one side. And then for the Cirrus, I have a second report here over on the right-hand side here, which is the ganglion cell analysis. And I do them side by side. And then also in my device, I'm going to have the photograph and visual field readily accessible so that I can compare that structure function part that I talked about. And then, we'll start to break down looking at each of the key areas. We may start up here in the reference database box, looking at average RNFL thickness, following the color coding, looking at what the normal values are, if any values are falling outside of normal values. Within this box, you have to be careful a little bit because average RNFL thickness can be a misleading indicator. Small focal defects of early disease won't push this into the red zone. So that's when you can have a patient with glaucoma and the color coding for the average RNFL thickness is still in the green zone. We'll probably also look at, I would look at the disc size to identify large discs versus small discs. I don't typically look at the CD ratio. Some people like to do that because they find judging CD ratio difficult to do. It's different from how you do it ophthalmoscopically at the slit lamp. If you like to do it, okay, but really, you really still need to be looking at the optic disc ophthalmoscopically. Next, I would, so there's the disc area. Next, I would go over and look at that color map. And just as Joe indicated earlier, you can learn a lot about the picture on the wall. So here on this thickness map, you see a dark blue wedge defect infratemporally on this patient's right eye. And then the way this instrument puts it together, they use a deviation map, sometimes known as a probability map, to show you and highlight the areas of abnormality that are going to get color coded in the yellow and, more importantly, more intensely, the red region. And so when you find things in the inferior temporal or superior temporal zone, you look for those characteristic patterns. There's the looking at the deviation map. You can also look at the disc parameters and disc size, and you can even follow the outline of the cup margin and identifying notching and other changes, so that when you go look at the optic nerve, if you have difficulty examining the optic nerve, look at this thing first. You may need more magnification here. You may need to zoom in on it, but you'll be able to see some decent contour outlines of the disc margin and inner cup margin. Here's the RNFL thickness map. I've talked already about this circumpapillary RNFL thickness. This is this the infamous T-SNP curve that identifies where the patient should be in the reference database. And here with the red arrow, I'm pointing out that there's a dip for the right eye, which is the solid line right inferiorly. And so as I see that there's a defect up here inferiorly, I see it on the deviation map. I also see it down here. You try to get all these things to line up and be in agreement so that you can make your most definitive diagnosis. It's helpful to inspect the circumpapillary RNFL scan or B scan down on the bottom of the page. It's not very well displayed on this report. It's not large enough for segmentation failure. So when the OCT is identifying the thickness of the retinal nerve fiber layer, it sometimes doesn't do it correctly. And you have to be smarter than the OCT device. You have to have your own brain power is still required here. And so looking to confirm that the OCT did its job and identified the anatomical layers of the retina, in this scan, the retinal nerve fiber layer, is part of your job, if you will, in this analysis. You may look at the RNFL quadrant plots and clock hours. Some people like them, some people don't. We have to all agree, though, that they can be misleading sometimes because they do not always show you the abnormality. It can be masked, or sometimes they can overstate it. So be careful there, and we'll show some examples of that later on. And then I would, go through and take a look at the ganglion cell plot for the right eye. Again, I'm highlighting this wedge defect that happened in here on this scan on the thickness map here for the right eye. It's likewise displayed on the deviation or probability map right down below. And all of this agrees anatomically with what's going on inferiorly for the retinal nerve fiber layer. And essentially, these regions are connected anatomically, and we'll talk more about that and how a new display can help us identify that in a couple of slides. So in summary, if your device has them, and not all devices have deviation maps, they virtually all have thickness maps of some type, use a thickness map in conjunction with a deviation map to identify these characteristic nerve fiber bundle defects thinning to the retinal nerve fiber layer in our characteristic regions, superior temporally, inferior temporally. Don't pay too much attention to scattered, isolated things randomly out here or on the nasal side of the optic disc. That's more likely to be some type of artifact or other type of retinal disease. Here again is a classic superior temporal nerve fiber layer bundle defect seen both on the thickness map, sometimes seen on the deviation map. And as Joe showed you earlier, use both of them together because they don't always show you what you think you should be seeing or need to see. And here's another example.
Mike,
A
if
few
you can go
more
back,
examples.
if you can go back one slide
Yep.
to the next previous one.
Oh, okay. Here.
Okay, I'm sorry. Yeah.
Yep.
This is a fantastic example. I mean, this is good quality imaging. The machine has done its job. You say it's got to do it. It has done its job. Now we have to do our job because there's so much conflicting data here. So much of this abnormal person has fallen into the normative data range. And I can tell you on this, and I think this is a great example and a great device. Thickness map RNFL, thickness map GCC. That's what I believe here.
Yep.
Fantastic.
Even though the average RNFL thickness is still in the green zone at 81 microns, and we're going to talk more about that and the reference database finding.
And everything else looks great. So it's done its job.
Yep.
We have to do our job in
Yep.
interpreting this and weighing it based upon our experience. This is a great example.
Yep. That's, again, the good classic examples are easy. There's, of course, a lot of in between. And so the only way to really train, I think, and to get good at this is to see a lot of the classical examples. And so that you know it when you see it, because the instrument's done its job, as you said, Joe. And then we fill in the extra data, the visual field, the color photograph, the IOP, the risk factors, the corneal thickness, all of that stuff. Again, just other examples here. And again, your device may show this a little bit differently. I'm not saying this is the only way to do it, but you know, these are the types of defects that we see in early glaucoma when using a thickness map and a corresponding deviation map. Here is the top half of the report from this device. Here's another example of, you know, a pretty significant retinal nerve fiber bundle defect superior temporally. And yet, if you just looked at the average RNFL thickness, it's still in what we call the green zone, the green range at 77 microns. Now, we're going to go through again this, what is normal in terms of microns of thickness and what the reference databases tell us that, so you can be more familiar with those numbers. Here's you know, an isolated area for this left eye out here. You know, that's something to watch. It doesn't go all the way back to the optic disc. You know, it really would depend on the findings for that left eye as to whether or not that's an early defect. It very well may be, or it may be some sort of artifact in that area. I'm more confident when we've got the blue, when we've got the defect, and here I'm looking at the blue, whether or not it's going all the way back to the disc margin. Sometimes these isolated ones can be examples of other artifacts. And just another example of somebody with more severe disease, a very large disc size. So look at the disc area, it's 2.87 millimeters. You know, normal disc size is about 1.8 to 2.0, maybe for Blacks and Hispanics, 2.2 to 2.4, but this is quite large. So the CD ratio is going to be extraordinarily large. The neuroretinal rim thickness, which is in the plot here, is going to be very thin. But there is very diffuse loss to the retinal nerve fiber layer in the right eye and a very focal defect superior temporally in the left eye. In this case, it's significant enough to lower the average RNFL thickness down into the red zone at 68 microns. So when the focal defect becomes significant enough, that's when it can start to affect the average RNFL thickness value. It's all about the statistics there. Just other examples here to show these classic examples. And again, I'm using a lot of device, you know, just one device here so we can sort of drill home these points, but you will find similar things on other devices. Here's the ganglion cell layer map, which on the Zeiss instrument includes ganglion cells and interplexiform. Macular scans on other devices technically actually include other structures than just this. Some of them do ganglion cell alone, some of them do ganglion cell complex, so there's a little bit of nuance in there. Again, do the same thing with thickness and deviation maps, comparing and contrasting them, making sure that they agree with one another. Here on the lower right, you see this sort of cookie cutter, very circular pattern that happens in just the way that the device analyzes the thickness of the ganglion cells in the macular region. It's certainly not perfectly circular like that. That's only the data that it has to analyze. You have to be careful with this circular, diffuse loss. This may not be always representative of glaucoma. In fact, there's a lot of artifact that we can see in the macular zone. Of course, there's lots of other macular diseases that can coexist in our glaucoma patients. So a color photograph and macular examination is really essential. And be aware of more varied and more likely to get false positive readings, meaning not true glaucoma with macular ganglion cell scans on your glaucoma patients, particularly when they have other existing ocular conditions. Again, taking you through the report: average RNFL thickness, thickness map, deviation map, neuroretinal rim thickness, where there's a notch to the neuroretinal rim, and then thinning to the retinal neurofiber layer thickness map down here, where it's basically dropped out. And here's what the visual field and optic disc photograph looked for that previous patient. So again, glaucoma is very evident in these cases, and I'm showing you the obvious ones so that you can know what glaucoma really looks like in the middle to moderate stages. When you don't have all of that, I think one of the things I emphasized in my October lecture was you can generally be patient with glaucoma. You don't have to diagnose it all in one visit. The patient's not going to go blind by the time you bring them back in the week or 2 or 3 to repeat some of these findings, or not do all tests on a single day to get a second or third IOP measurement, or to reconfirm your findings is really the take-home message there. Here's a variety of circumpapillary RNFL thickness plots, the T-SNP curve. These are, again, are pretty classical. And again, for some cases, it can be really helpful to look for these areas where the retinal nerve fiber layer thickness has fallen into the red zone, the abnormal zone, and that it corresponds by location to what you're seeing on your thickness map. It just makes everything in an agreement. It may be an extra step or extra, couple seconds for you to look at on the report, but it's going to make you a better, it's going to give you a better and more accurate diagnosis. And that's why you want to take the time to do it. Sometimes you'll get a defect and it doesn't go all the way down into the red zone, but it's still a very significant defect for the superior temporal retinal nerve fiber layer bundle for the patient's right eye. Match it up on the thickness map. Match it up with a field defect if it started. It may not have, but that's the way you confirm these things. And then here's some abnormality on this one. Now note on this T-SNP curve, the most important region is out here at the edges in the temporal zone, because we really want to look at the temporal region along the neuroretinal rim, or just outside the neuroretinal rim on our retinal nerve fiber layer circle, because that's the most key region. And unfortunately, this plotting of the T-SNP is backwards, and I'll show you an update to that in a couple of slides. Here again, you can dive down to whatever the metrics are, wherever the data is located with your OCT report. I don't think you need all of them personally, but I focus in on the average RNFL thickness. Sometimes I find the symmetry one not to be very accurate, so I don't always look at that. I don't really look at rim area. I do definitely look at disc area or disc size. As I said earlier, I don't pay too much attention to the CD ratio. It's something I'm just going to make my own estimate on, and it's going to be different from the OCTs. It's using different cues than I'm using. So here we get into a slide that tells us a little bit about this reference database. And so every device has submitted to the FDA several hundred patients, all normals, all without glaucoma disease, and have quantified the range of retinal nerve fiber layer thickness in a normal healthy population based on age, based on different decades. And so what I'm showing you here is the 95th percentile down to the 5th percentile is a range of over 25, almost 32 microns of RNFL thickness. And so, while people can start in the middle here and it will be normal, many people start at the top, lose RNFL all the way down before they get to the 5th percentile, where the range is only 8 microns before they get into what we call the floor, which is somewhere below 65 microns or under 60 microns, depends on the device, and or actually down to 50 microns, I should say. And that's where the OCT is not going to give us any further information. So 2 important points. One is patients have disease in this green zone up here, and they're losing RNFL thickness. They may or may not have a visual field. By 75 microns, they generally start to show a visual field, although not always. And then by the time they're down here, there's no point in you doing the visual field, no point in you doing the OCT anymore. They're not going to continue to progress. And if you ever see a 0 for RNFL thickness on your OCT device, that means that the OCT did not segment the RNFL thickness, and it just gave you a 0. There's no such thing as a 0 reading for RNFL thickness. So here is just another slide reiterating those guidelines and the normal ranges within the reference database. They're not exactly the same between all devices, but generally quite similar. Here's that floor, and we're at 64 microns. I think that says, maybe it says 54. 54 microns for this patient's RNFL thickness. See the diffuse blue. You see scattered RNFL loss on the deviation map infratemporally and more so superior temporally. And then look at the visual field. It's only at a mean deviation of about, I think that says -8. And so that has to go all the way to -30 or -32. So there's a lot of visual field left for this patient. And in this type of glaucoma patient, it's most likely to go quickly because they've burnt through or, used up all of their retinal nerve fiber layer and retinal ganglion cell axons, and the disease may progress quickly.
And interesting, Mike, that would actually consider be only a moderate glaucoma.
That's right. This is where I sometimes disagree with that scale, Joe. And even though it tells me to say moderate, I'm going to put down severe.
I agree. I agree entirely.
Right. But I do generally try to follow the guidelines. But, for me, it's coding. It's like, I want to make sure I know that this person is severe because I treat them differently, of course.
And the nuances, I'm sure, explaining that to students and the residents is really challenging.
Yeah, exactly. Follow the rule, except. So that always goes well, right?
Do what I mean, not what I say.
That's right. Here's another example. And this is an interesting case, Joe. And I've talked about this woman a couple other times. I don't know if I did it back in October. But she's this superior temporal defect in the left eye, large disc size, 68 microns, no field loss on a 24-2, no field loss, early field loss on her 10-2, but not as much as you would have predicted based on, looking at her OCT. I've mentioned already a few times, and we've talked about this green disease enough, so I think people are familiar with that. There was a field defect for this patient. So again, you can't predict just based on early OCT, they probably won't have a visual field, therefore I don't need to do it. You need to get good baseline testing. And some of these patients, when they're good test takers, they will show you early disease on visual field. And as I just shown you, 10-2 or some of the other new options from Zeiss, including the 24-2C that has extra central points, is another option. But any test of threshold visual field is satisfactory. You don't have to have just Zeiss. Sorry, Zeiss people. Other examples here, I think I can skip through that. We've talked a little bit about the optic nerve head analysis. This is just to reiterate that, yeah, your OCT device is finding the disc size by the opening of Brooks membrane that's down here at the end of the RPE. And then it's identifying the overall disc size. And it's then identifying a contour line to show you the cup shape. Again, it will be a little bit different from what you see stereoscopically at the slit lamp, but it can be helpful. Here's where you get the disc area and disc size, and I'm just highlighting those different aspects to you. Remember, our circumpapillary RNFL is from out here, and right around here, superior temporally, you would see that T-SNP curve dip down into an abnormal region because of the loss of tissue there. For our macular scans, again, I've already highlighted that we are just taking a couple layers in the middle retina, ganglion cell and interplexiform. So it's quite challenging. And again, you can find artifact and other disease in the macular region. Joe, it's time to make sure everyone is still with us and pop up one of the questions.
I just launched it. OCT scans for glaucoma do not include which of the following: neurofibrillary thickness, macular ganglion cell thickness, RPE thickness, cup disc measurements, or I'm not sure. That's why I'm here, which is something we've always started adding on as a viable option, as an answer.
Perfectly fine.
Yeah. I mean, maybe not for student exams or national boards, but
right. This is just a metric to make sure everyone's here.
yes. And we're getting a nice return already. People are awake and with you, Mike. And there are no questions in the chat box, which tells me that you are really clear in what you're talking about.
Thank you. Or there's something happening in some sports game going on right now.
Mike, when you look at at OCT printout, do you look at the disc parameters much? How much do you put into there?
I don't always, Joe, but I do on the difficult cases or the funny shaped nerves. Mm-hmm. So I don't use the disc parameters. I don't want to mistakenly mislead anyone to say that I'm using them for a diagnostic purpose per se, but you know, they can be too variable to really use diagnostically, but I do get the funny shaped nerves, the large discs, the small discs, the masqueraders, and that's when I need to know about what's going on with the disc, and I'll take a more careful look at that time.
You know, I like looking at for the disc area. I like looking at, you know, the vertical cup to see if we agree with it. And even though it's been validated by a number of studies, I'm with you, Mike. I don't use it much, and a lot of people in the glaucoma community just don't.
Yep.
Yeah, I think we've all landed feeling much better about neurofiber analysis and ganglion cell analysis.
Yeah, yeah. I guess, Joe, what I would say, and part of what I was trying to get across on my earlier slides, and maybe I'll just back up for a second, is that for those who are having, why can't I move here? I'm blocked here for a second. Oh, here we go. So, and this one doesn't show a notch, it just shows a generally enlarged cup. But for those, when you're examining the disc ophthalmoscopically and you're trying to identify, you know, as we should be doing, I'm trying to encourage people to make sure you're still looking in the back of the eye. This diagram here, not the metric, so again, a little bit different from what you asked me, but this diagram sometimes can help my students identify where a notch is, where the disc margin is, things like that. But again, it's soft, no doubt.
Mm-hmm. Well, you see the results of poll number 1. You know, most people got that right. And Mike, a question did come in just now. I think it's a very pertinent question that relates to a lot of people. Does the RNFL thickness naturally get less in healthy eyes with increasing age? Or maybe another way to phrase it is, how much age-related decline is acceptable?
Yep. That's a great question. I have it later on in the lecture, but let's talk about it now. We know from several studies that normal individuals lose about 0.5 micron per year of RNFL thickness. So that needs to be factored in somewhat. Now it's factored into the reference database. And as you are looking at your color coding, your red, yellow, and green, it's factored in on a diagnostic standpoint. It's not so much factored in on a progression standpoint for patients that you're following over time with your OCT. But yes, half a micron per year is normal age-related change.
And
And
here,
so,
and
go ahead.
here's my challenge with that, is that comes from very good research in trained observers, good quality patients, and people who are using the device the way Elton John plays a piano. Now, when we have real world practice where you have different students, I have different technicians, they're not all created equal. And that's why what we know the variability is, and the variability in real life can be a lot greater. And that's hard to ferret out due to the quality.
Absolutely. Under optimal conditions, perfect conditions, OCT vary by 2 to 4 microns between scans in terms of reliability. And so when you look for change, and again, this is getting into some of the progression part, but when you're looking to make a diagnosis, you're looking for at least double that to be as certain as possible that the change is related due to glaucoma or some disease process, and not due to aging or to variability in acquisition and scan imaging.
And that's why I like a visual field. I like to see it reproduced on the next one too.
Yes. Yep.
Hey,
OCTs are, we can certainly agree, OCTs are generally more reliable than a subjective visual field test. But just like you said, we've got many variables in with our patients and our technicians and everything else.
Mm-hmm. Mike, another question came in. Can you address small tight optic nerve and RNFL loss?
I am going to get to that in the Masqueraders section a little bit.
All right, very good. We'll table that discussion for now.
Yep. Okay. The next section, I gotta move this out of the way again, is just to identify that sometimes these two reports can be really cumbersome to work through or work with. And that, the loss that we're seeing in the macular region is related to the loss that we're seeing in the retinal ganglion cells. The red arrow here is, reminding you that this is all connected together. And even though this one instrument used to do not a very good job of putting it together for us, we needed to think that way. We needed to think anatomically and from a pathophysiological standpoint. We're not just looking for red stuff on our report. But in the past few years, this instrument has improved, in my opinion, at least to a certain degree, by stitching together the RNFL on optic disc scan with the separate scan that we do in the macular region. And so we're looking for same side correlation between these two abnormal regions that we're seeing on the deviation map or on the color map up above. So yes, we take first one scan of the optic nerve head, we reposition the patient, change fixation, scan the macular region, the device then stitches it together, and we're able to look at both at once, which to me is more efficient, saves me time. And when I see things that are agreeing on the same side of a horizontal midline here, because glaucoma disease generally affects, at least early disease, one pole over the other pole, meaning superior or inferior. It generally happens asymmetrically within the optic disc. And those things are agreeing with one another. That's a stronger statement for me that the disease or the damage is due to glaucoma versus what you might see here, which is maybe just some artifact, these little red, yellow areas that are not consistent with anything. And so I don't diagnose glaucoma based on that. I'm looking for more of this type of stuff here. Now there's still some artifact where you get this circular pattern in the ganglion cell region. So it's not a perfect matchup, but these so-called PanoMap reports from this device are helpful. And some of the other devices are moving in this direction also.
Mike, years ago, when this was still coming out and the ganglion cell was really gaining prominence, I started noticing a trend in these patients where I look at the GCC and it wasn't that impressive. I look at the nerve fiber layer, isn't that impressive. But I actually started stitching them together myself with the Photoshop program. Yep. And when I stitched them together, I realized this was greater than the sum of its parts.
Yes.
So I reached out with these examples and sent them to some friends at Zeiss, and they were really, really interested. The person was, very, very interested, and said they would talk to somebody about it. And about an hour later, they called back and said, "Yeah, we got that already. It's called a panel map." I thought I invented something, but they gave me a firm attaboy. Like, keep trying, you'll get something eventually.
Right. But isn't it interesting? They had it. It was available in Europe, but they didn't really talk about it in North America, or wasn't marketed or approved or whatever the heck it was, some of the silly story, if you will.
And I thought I was onto something.
Yep. So here's some other examples. And again, the concept is to have everyone take a step back, look at the patient, think about the disease, think about the pathophysiology, make sure that things are making sense, if you will, an agreement within the disease process of glaucoma, so that, here's a really good example of what you might see in early disease on the left here. It doesn't, everything is not exact. It's going to be very messy. It's two separate scans. We're talking about the nerve fiber layer here and the ganglion cell IPL layer here. So it's not exact, but they're all connected together. Sometimes you'll see this diffuse stuff in the macula, but you still see RNFL. Where I get concerned, and Joe, chime in here, if you just see the ganglion cell and no RNFL, I'm much more hesitant to call that glaucoma just based on that alone.
Indeed, unless on the thickness map you have that nice cut at the horizontal raphe.
Yes.
I've always referred to it as a nautilus shell sign.
Yep.
Sometimes like looking at one of your examples earlier, I started thinking about calling it the airplane neck pillow sign, because that's what it looks like.
Where do I have one here? Yeah, sort of upside down there, but yes, I showed that earlier. Maybe we'll see it coming up. Yes, but these round cookie cutter things, be careful with those, is the bottom line.
Yeah.
And you may look at the macula. I look at the macula. A lot of these patients, I don't always see disease. It's variability within the reference database. Reference databases are not perfect. Here's some, very early, I think this is the case that we saw earlier, and I don't know where the panel map is for this one, but that's what we're talking about tying together. So again, look at your report, consider your instrument. For those of you that are using a TopCon device, they do the 9 by 12 millimeter scan, including the optic nerve and macular region all in one scan, and yet they don't fully show you those two scans together. But we'll take a look at those reports coming up in a little bit. Again, here's your little nautilus sign, Joe.
Mm-hmm. And to me, that is very compelling.
Yep. And in this case, it goes very well with the inferior temporal retinal nerve fiber layer loss on color and deviation. Look at the optic disc, got a photograph of that, and there's, significant field loss. This is a report from the iView instrument. And actually they started, I think they were the first device to link together in a display the optic nerve head and the macular scan all in one. So I give them credit for doing this first. They're using more of a color map here. And you need to sort of link together the RNFL, circumpapillary RNFL thickness plots out here, and then draw that over here. But this is anatomically a representation of a direct view into the back of the right eye and a direct view back into the back of the left eye. And then again, they have all of their plots and numbers there. And so again, you could do virtually the same thing that I've just done with the Cirrus device on many other devices. Here's an example from the TopCon. The TopCon, I think, is great because again, you're getting a 9 by 12 scan all at once, and you're also getting a color photograph. They really only have the color map. They don't have a deviation map. They do have quadrant and clock hour reports. They put the average RNFL thickness down here in the corner, and they've changed this to not the T-SNIT, but to the N-STIN. format. So this circumpapillary scan around the optic disc to get the thickness of the retinal nerve fiber layer, they've now cut it open in a different way to give us NSTIN. And so here is this dark blue line is where we're getting our data from. This is sort of, agreed upon by everyone to get RNFL thickness data at a circumference of, boy, I can't remember what it is now, 1.75 millimeters, something like that. And that's standardized size between all devices. And so we plot the thickness of the RNFL and then unfold this line out and plot it against the reference database. A dip here is quite significant. In the NSTIN plot, the temporal region, the most important region, so right over here for this right eye, is put in the middle of the report. And that gives us a whole, gives us a much easier way to identify change. So dotted line is the circumpapillary RNFL. We cut it open on the nasal side and we stretch it out here to put the temporal region in the middle where it's easier for us to read. That's all it is. And so you may see that on other devices as well, as this is, I think, just a better way to do it. And hopefully everyone adopts this and gets on board with it. Again, I like this because we have a photograph, we have cross sections of our B scans, we can sort of see the segmentation. We've got disc topography metrics for what we need, just disc area, vertical CD, as you mentioned, Joe. We've got our NSTIN plot in the middle, a thickness map, and our quadrant and clock hour plots. And then for somebody who's abnormal, and this is actually a slightly different report that was created by Don Hood, he even magnified the B scan to an even greater degree. So you can really see these two green lines, which is what we call the segmentation. Those two green lines are defining the thickness of the retinal nerve fiber layer. And they don't always get it right. So you really need to inspect that. It's very thin in the temporal region here. You can compare the thickness up here. You see it falling down into the red zone down here. And on the thickness map down here, so RNFL thickness map here, you see, well, it's a little bit difficult, but there's a wedge defect in there. And there's certainly not the normal thick coloration that you would see, normal hourglass shape thickness that you would see. And then Don Hood has added in what he calls, what is a probability plot in field view. So he flips this upside down and then superimposes a 24-2 grid so that you can line up the RNFL defect with a visual field defect that should follow the same shape. And I'll show you that on the next slide. And then just to finish off this report here, Don, of course, helped identify for us how important doing 10-2 visual fields are and scanning the macular region is for early glaucoma. He has the ganglion cell map for the macular region, and everything in red here is abnormal on this probability plot. And so how you would use this in theory, now it doesn't bring in the visual field data, just like you were doing a couple of years ago, Joe, or several years ago. You were cutting and pasting the field defect next to the RNFL defect on the OCT. And so again, what Don has done here is flip this and inverted it so that we have field view. So that when you look at your visual field, you line up the red region with your black squares on your pattern deviation plot from your visual field, and they should be in agreement. Won't be perfect. Human eye isn't perfect, but they should generally agree with one another. And so that's just one advantage of the TopCon instrument. And I think a great way in terms of taking steps to make identification of glaucoma via structure and function easier for us as clinicians. Of course, the Spectralis is a great instrument. It has a number of reports, very high quality imaging, and also a report that was designed by Don Hood to do basically the same thing that the TopCon report does, which is show you the B scan very clearly so you can look at segmentation, give you clock hour reports and an NSTIN map, retina view in thickness map, and then field view where it's flipped upside down so that when you look at your visual field, the visual field is lining up with the RNFL defect that you see inferiorly. And when you can put all of this together, look at the photograph, look at the OCT, look at the visual field, even early patients with just a couple of points on the visual field or no points on the visual field, or just a small slender wedge defect on the OCT, you'll be more confident that you are identifying true glaucoma. And is this another example, or the same example, just showing you a slightly different way? So again, lots of reports, more similarities than differences overall, but it's difficult for us to talk to one another when we have these different instruments and different displays. Okay, Joe, question time again.
All right, I'm going to launch the poll number 2. The thickest portion of the optic nerve, neuroretinal rim in a healthy, normal individual is usually temporal, nasal, superior, inferior, or I'm not sure. That's why I'm here.
And this, just to be clear, this is more based on ophthalmoscopic examination of the optic disc, not OCT. If that helps or hurts anyone, I don't know.
Well, people are awake.
That's
We have
good.
results coming in.
We're
I
like,
don't see anything new in the chat room.
good. We got a ways to go.
All good. Well, if you've got a lot more material to cover, I'm going to end this. We have a nice participation here. I'm going to end the poll. I'm going to share your results.
Very
The
good.
majority says inferior.
And they are correct. As soon as I change my slide, you'll see why. So yeah, if you remember the isn't rule, not something I do for every glaucoma patient. Again, it's one of those tricks I pull out on the hard ones sometimes and see if it's this rule that the inferior should be the broadest, widest portion of the optic of the neuroretinal rim. And that if it's not, you're sort of in violation of this isn't rule, and it's one other, mnemonic to help us evaluate the optic disc overall. It sort of goes along with our OCT analysis. And again, it was a reminder for me to say, we're not just doing the OCT, we're looking at the optic disc as well. We're doing visual field testing. Okay, so let's get into our masqueraders and confounders section. I tried in the past hour or so to show all the things that we really want to look for to identify glaucoma disease in our patients. Yet many of our patients that we see who are suspected of having glaucoma actually may have something else. And Joe, I'm sure you can attest that we see lots of referrals from our friends who think a person has glaucoma and really it turns out to be some other type of condition. And just because it's an OCT device and you're looking for glaucoma doesn't mean it will find glaucoma. And so I thought I'd share a couple of cases so that we could at least remind everyone that the OCT device will find what it finds, and we need to be a little bit smarter than the device sometimes, and we need to take a more careful look at all of our testing device. So here's a patient. Pressures were in the 22 to 24 range. The discs are small. They may have a little bit of an unusual appearance. I'll leave it at that for right now. Not sure. There may have been some family history for this patient that was a little bit suspicious, but again, it prompted a referral because the clinician wasn't exactly sure what's going on, which is perfectly fine. We did a threshold visual field. The fields in this case were normal. We did an OCT, and so really pretty normal for the left eye, for the right eye. Maybe, what you might call the wedge defect that I've been showing you already. Doesn't quite go all the way back to the optic disc margin. You should look on the photograph down here for the left eye. And, since we can see the retinal nerve fiber layer a little bit in the color photograph, I'd want to try and confirm that I see RNFL defects there, but maybe you really maybe need to take a more careful look about what's going on within the optic disc and not so much outside the optic disc. And in this case, we've got a patient with disc drusen. And, mild disc drusen can sometimes emulate glaucoma based on the visual field loss. Usually in the disc appearance, it's very different from what we see in glaucoma, of course. We see a small crowded disc, lumpy, bumpy, and, drusenoid bodies within the optic disc. But in this case, with high pressure and perhaps a family history, was sent the clinician off down the wrong pathway. And then the OCT finds something that looks like glaucoma, and everyone just gets naturally confused. So there's lots of information. Joe, I know you've done a lot of you've written papers on disc drusen, and you see this stuff a lot. Some of the latest information is to make sure that you're doing the best OCT, so-called enhanced depth imaging or the high definition imaging, to help identify the drusenoid bodies that are developing within the optic disc, and again, maybe developing into field loss that may emulate glaucoma in some stages of this condition. And so these were recent guidelines from, I think, published in 2020, or guidelines from 2018 on how to handle this optic disc drusen condition. And depending on your instrument, you'll have some form of enhanced depth imaging that can highlight the drusenoid bodies a little bit more clearly. And I guess the general point is that you got to be careful. Here's a 29-year-old African-American woman, suspicious disc, 20/20 vision, normal neurological exam, history of migraine headaches, no double vision or transient vision loss. Fields could be, an early case of glaucoma. But the disc examination certainly shows something different. And the OCT, again, if you're thinking glaucoma and you're only looking for glaucoma, sometimes when you see all this weird stuff on an OCT, you just think it's glaucoma. But really, you got to go back and image the optic disc with this EDI, or high definition scan. And there you can see more clearly the changes within the optic nerve head for drusen. And then here's the same patient scanned with the Cirrus device.
Mike, if you go back to the previous example, I think several people may have the same question. The previous example, the patient with pressure of 23.
Oh yeah, my first case.
Yeah, I guess my question is, do you treat this person?
Yeah.
So why?
I left that out because I'm not sure. At the end of the day, I felt that this was more drusen than glaucoma.
I definitely agree with you.
Right. The pressure concerns me a little bit. I don't believe there's any real evidence for lowering IOP in patients with optic disc drusen. And so I generally, me, Joe, I'm going to end up sending it to Len, and Len will do what he will do. But I'm generally not in favor of treating these patients with IOP lowering medications. Now, this patient may have been a little bit different after time. I can't quite remember. If the pressure was regularly over 21 or something, I suppose there's an argument for it. But if the pressure is normal in this patient, I'm certainly not going to treat. That would be me.
Was there a central corneal thickness on this patient?
Yeah, I don't remember.
Interesting. I think with a pressure of 23 and you're losing, you got a confounding factor, I might be a little bit more inclined to treat. A pressure of 15 or 16, absolutely not. I wouldn't do it that. But you've got really pristine visual fields, and I think you can follow them with that very well.
Yep. Of course, the drusen can progress and cause progressive visual field loss. But we'll have to, I think how old was this patient? 64. So.
Generally time is on your side.
Yep. Okay, so that was drusen cases, myopia cases, also things we see every day. Myopes are glaucoma suspects. Some myopes with, bad retinal disease, progressive degenerative myopia, staphylomas, macular scarring, normalish pressures typically, oblique and tilted insertion. This is a very high myope. I don't remember how high, but probably 8, 9, or 10 diopters of myopia. These are tough patients. The OCT just does not work for them. And, don't even bother on most of these cases. Look at the visual field. That's not going to work for the left eye. For the right eye, we got something a little bit more reasonable. But you still have this tilted disc. And, do you really have a glaucomatous defect there? Let's look at the optic disc. It looks, the disc looks small, tilted, some staphyloma or peripapillary atrophy, a small cup, a good rim perhaps. This looks like glaucoma, but it doesn't go back to the optic disc or to the RNFL.
Mike, looking right at 9 o'clock on the disc, is that a disc hemorrhage?
Yeah, I don't think it was, Joe, but I see
Okay.
that right in there now. I don't think it was. I think it was just a vessel.
And if I see him in the cup at 9 o'clock or not in the glaucoma prone zone, I just call it a hemorrhage of the disc. I don't call it a disc hemorrhage.
Yep. Yep. Here were a series of fields for that patient over 3 years. So it was just, it was one of the cases that I have that, okay, OCT for the left eye, it's not going to happen. Don't do it on these high myopes. I think I have a couple other myopic cases. Tilted discs are a big thing. They really do complicate the OCT interpretation. And, when I prepared for this lecture earlier in the year, there's just a whole host of articles that, really sort of, reminded me of these changes in the optic disc and how, these are the hard patients to evaluate. And you see the photographs here, and there's a whole host of explanation about what's going on in there. And the bottom line is that you have to be really careful. I don't think here in this session this evening we're going to become experts in OCT analysis on myopic tilted discs. But the take-home point is don't rely solely on your OCT, and what you may be seeing is just retinal disease and myopic disease and not really true glaucoma. What is interesting is that some of the articles showing all these examples here did find that there can be some progression with the tilting, so sort of like progressive myopic degeneration, and that could contribute to some changes on the OCT. Whereas generally, I like to say that glaucoma is a progressive disease, and you can use that as to your advantage of waiting for progression before you diagnose a patient. Next patient is a 7.5 diopter myope, pressures of 23, had many years of routine contact lens and eyeglass examinations. Pressures before this were, just at 20 or a little bit under 20. You see the classic obliquely inserted disc and a little bit of peripapillary atrophy. Both discs there. I'm not really pointing anything to the nasal side. It was just really to look at the discs there. Here are the OCTs. Lots of loss on both eyes, and sort of, not maybe fully characteristic pattern because of the myopia. And the, ganglion cell map, not very helpful at all. So I'll focus on the RNFL. I'll look at that. I got to go back and look at the photographs, and I certainly have to use my visual fields. And although this was, that's an unreliable test on the right eye there with high false positives, over time, doing enough fields showed me the true field defect. Now, fortunately, we were able to lower pressures and stabilize the disease over this 5-year time period. But, just another case of where myopes are tricky patients, and OCTs, unfortunately, don't always bail you out. Here's another Asian 6.5 diopter myopic patient with pressures of 21. You got to look carefully at the optic disc and neuroretinal rim infratemporally. Here's the, that's the OCT for the right eye. OCT, hold on a second. I think I have got the, sorry. Where's my OCT for the left eye? All right, what am I showing here? So I'm showing a defect here inferiorly on the right eye. And on the photograph back here, we're talking about down there, which I don't see so well in the photograph. And then for the left eye, here's the left eye. And there's the wedge defect that I was pointing to. So look at the thickness map. Remember that? You've got a photograph there. It may not be so evident on the photograph. Look at the disc outline. Look at the cup margin and neuroretinal rim. Look at your end-stin plot. And look at your clock hour and quadrant plots. Look at your average RNFL thickness. But sort of the take-home display for me is this inferior temporal RNFL defect there that really sings glaucoma to me. And there's the field for the left eye for that patient. And then that same patient with the panel map report from the Cirrus device. So I told you inferior RNFL defect leading into the ganglion region. And it did find something inferiorly on the right eye like the Topcon device did. So there's, again, lots of confounders and masqueraders. The OCT cannot always identify glaucoma in these patients. And, try to use all the tools that you have. And if you don't have the tools, try and get this imaging for your patients. Time for next question.
Another poll question. All right. Poll number 3. I'm going to launch it. One method of differentiating glaucoma disease from myopia and other optic nerve anomalies is measuring pressure, taking a color photograph, using pachymetry, looking for change over time, and I'm not sure. That's why I'm here. And a number of people are rolling in very quickly, so we're doing very well. And I don't see anything else in the chat room, Mike, so we're doing terrific. Okay. Just a few more seconds for a few more people to roll in. All right, I'm going to end the poll and share the results.
Perfect.
And looking for change over time, progression.
Perfect. Again, interesting that that one article said that that might not always work for tilted discs because those can change over time, but that's generally the answer I go with.
Mike, I hate reading papers about tilted disc, only in that there are 3 anomalies out there. There's obliquely inserted. There's true tilted disc, which is a coloboma, and there's a relatively uncategorized obliquely rotated.
Yeah.
And these are 3 anomalies that I think are entirely different, but they all get lumped into the same papers.
Yeah. Isn't one of them more of twisted?
Well,
like a rotated one? I think of it as being twisted.
Mm-hmm. Well, there's obliquely rotated, there's true tilted disc and obliquely inserted.
Yeah.
And, oblique insertion common in myopic eyes and Asian eyes, but they themselves shouldn't have any abnormalities. Tilted disc can have multiple abnormalities. And the obliquely rotated, nobody's really categorized that so much. And when we look at the papers, they just mix them all together. And I think there were 3 different things.
Yeah. I guess I should mention the one question I always get, and I meant to, hopefully the section helped to answer it, but I perhaps did not answer it directly, which is, what do I do with my 8, 9, 10 diopter myope who I think has glaucoma? They still want to know what to do, and it's a fair question. I tried to point out that the OCT is not going to help, and I think I would just try to reiterate that, be cautious. Patients with very high myopia are more at risk for glaucoma. Our population-based studies have shown that the optic disc is compromised by perfusion pressure and blood flow. But at the end of the day, there's no easy call as to whether or not those patients really have glaucoma or just retinal disease. And sometimes you just have to err on the side of, well, it's probably best to at least treat this patient a little bit and make sure your treatment's effective and well tolerated and safe, especially when there's field loss that goes along with the abnormality of either high myopia or early glaucoma.
And in those anomalous nerves, the question is the field loss congenital or acquired?
Yep.
We all have those patients,
Yep.
where we just don't know if we did the right thing.
Yep. But I don't generally keep doing OCT on them a lot, but anyways. Okay, let's do some cases to wrap this thing up this evening. This is a 55-year-old who has systemic hypertension, has a strong family history of glaucoma. First IOP readings were 23 in the right eye, 23 in the left eye. Pachymetry was really quite thick at 596 and 572. These are the wide field fundus images. The optic disc is a little bit blurry on some of these sometimes, but I do take a look at the retinal nerve fiber layer if you can see it, and sometimes it shows up pretty well on this camera. The disc margin, the cup, again, not a perfect device for glaucoma disease in my mind, but it's one of the cameras that we use in our general care service, and under optimal conditions, it can do a pretty good job. And again, we all have different cameras with different settings and different outcomes. So just be aware of that.
And I've always said, Mike, that one of our best imaging devices we've always had is the fundus camera.
Yep. Yep. You can, as long as we look at it.
And do it.
And do it, look at it, interpret it, and move on and look at the visual field. So normal field here early on for this patient who obviously is a strong glaucoma suspect. For this patient, I did corneal hysteresis. Does not have to be done. It's not a standard of care. This is that device that measures the cornea's ability, which is indirectly a measurement of the optic nerve's ability to resist changes or elevation of intraocular pressure. It's sort of an elasticity measurement. It's really just another risk factor that can be quite helpful, but don't have to have. In this case, the hysteresis at 12.6 and 12.4 is very high, and that's a good sign, meaning lower risk for the patient. So we've got a number of findings that are going back and forth. Modestly elevated intraocular pressure, thick corneas, large cupping, at least we could say, for the optic discs, no field loss. This, theoretically should lower the risk. Let's look at the OCT. And then you have to make sense of this. Look at the thickness map, look at the deviation map, look at our values for average RNFL thickness, look at the depth of the cup here. It's a very deep cup. Make sure that it's been, make sure it's a good quality scan by not just signal strength, but by centration and emotion artifact. Look at the pattern of retinal nerve fiber layer loss on this deviation map. It's scattered all over the place. That's not always typical what we see in glaucoma. We see something more like this with a wedge defect in the blue area and down below. And then we've got sort of our cookie cutter patterns on the ganglion cell loss next door. So to put all of this together, high IOP, thicker corneal thickness, tally this up and try and come to some consensus while you're thinking about what you're going to do with this patient. And at the end of the day, with the family history and the other risk factors for the patient, it was decided to initiate treatment in this patient. Although we rechecked the eye pressure another time or two, we didn't really find it any different. We start therapy with a prostaglandin analog. And actually, that's when she came back when she came back at a 1 month IOP check. without treatment, pressures were 25 and 26. And that was sort of really the tip off that at that pressure level, even with thick corneas and a high hysteresis, the strong family history and the OCT findings were suggestive of early treatment. We did another visual field over the next year to two. Not really anything significant there. Like where I would be looking though is I'd go back to my OCT and probably be looking inferior temporally for that defect that I see on the right eye. And what I see here is some scattered defects for the left eye. So I'm not sure what those are. Like you said earlier, Joe, need to repeat them. I'm not going to get crazy about them on this follow-up visit. Here's a flow chart of her IOP readings over a 2-year period. You see where we started treatment, lowered pressure, pretty, fairly well for a while, up until about 2 years later, still maintaining with good compliance and installation, but the pressure jumped up to 29 in the eye.
Mike, are you sure? Go back one, please. Good compliance, because your graph, your pressure graph, because I see 125.17 and 12.13. She disappeared for about a year. Was this person really being compliant?
Yeah, no, probably in there. I'm not so sure, Joe.
Mm-hmm.
But I think at this time she was taking her drops. Does that make sense?
No, I would think 19 to 29. And a year absent,
Yeah,
she might have dropped off in compliance.
Oh, I'm sorry. Yeah, you're right. You know what? I am misreading the dates there.
Mm-hmm.
I'm sorry. Yep. Thank you. I thought this was only a month apart and I was mixing up my January and December their dates. So yeah, that actually probably is without any treatment. And I guess the point I was trying to make here is like, even back here when we thought her high pressure was 26 in 2016, a year later, her high pressure really is 29 and it probably is sometimes in the 30s. Mm-hmm. So we don't always know what the peak IOP is. Let me see if I can do this up here. Maybe that'll help me. Just adjusting something. Then we added some additional therapy. I think we restarted the PGA. She came back down. We still felt that she needed additional therapy. I listed a number of adjunctive treatment options there. Pretty much all of them are fine. My preference would be to go with Combigan or COSOPT would be what I would typically do. And certainly talk about the SLT laser option because of her non-compliance. But we also got to make sure that she keeps coming in for the visits because, can't do that. Can't do a laser if you don't come in and get it. Visual fields for the right eye and left eye over time. Again, it seems to be okay for right now, but as the OCT shows, there's, continued loss there and the future is a little bit ominous for this patient. So we do need to be somewhat more aggressive with her.
Mike, a question came in. How much loss of nerve fiber layer above the 4-micron sensitivity of the cirrus and still be in normal green measurements tips you into treatment?
I think we're confused.
How much change, if they're still green, how much change before you say, I don't like this?
So I want to make sure I understand. If the average RNFL thickness decreases by, let's say, 7 or 8 microns from one test to the next, we're still in the green zone. So we go from 90 to 82 in one eye. If there is a corresponding arcuate defect and other corresponding findings, then a single change between tests within the green zone of at least 5, but preferably 6, 7, 8 microns is enough for me to think that there's something real going on there.
Okay.
Did I say that? I hope I answered that.
I think you did.
Okay.
I think we have time for another example, Mike.
Yep. So a little bit on progression here for the last 5 minutes or 10 minutes or so. This is just, what do you do? And these are some of the questions that were coming up. Monitoring the OCT over time. It's trying to identify slow progressors versus rapid progressors. This is two categories, if you will, two types of glaucoma patients. Most patients are slow progressors, but about 15 to 20% of patients may fall into a rapid progressor category, a more severe form of glaucoma. You can't really tell that just by risk factors or IOP. You can only tell it by measuring several visual fields, OCTs as well, to identify the rate of change over time. Do we want to do a question here, Joe?
Yes, we do. If you'd like to, I will launch that for you.
I think this is our last one. Or maybe only our fourth, can't remember.
This is our fourth one, so I'm going to launch it. What are two forms of OCT progression analyses? Event and trend, simple and complex, differential and regressive, vanilla and chocolate. Oh, I'm not sure. That's why I'm here. Okay, people are rolling in nicely. And I think we've covered everything in the chat room so far, so we're doing terrifically.
Good. We'll wrap things up here in a few more minutes.
Okay. So I'm going to end the poll and share the results. So there are your results. Most
Good.
people have chosen differential and regressive.
And let me tell them what the real answer is. Event and trend. So these are two terms, they're not printed anywhere in the reports. You wouldn't really know these terms. They just describe our two different approaches to looking at progressive change with both visual fields and OCT on our glaucoma patients. An event is a type of analysis where it's a more of a point-by-point change in an area or on a visual field test location between two tests or serially over several tests. And it's more a localized, if you will. And trend analysis is a regression line that is plotted of a series of generally at least 4 to 5 series of tests where we calculate the slope of the line looking for a significant negative slope. So again, just speaking to OCTs, this is the guided progression analysis report, the so-called GPA report from the Cirrus device. And this is the RNFL thickness map, deviation map. And right here in the middle is where the trend line analysis is. And the second type is event-based, showing you the color maps because it's more point by point, if you will, pixel by pixel of regions within that box to identify where change is. So these reports or whatever device you have, and again, this is an area where there's lots of differences between instruments and software and devices. But for those of you doing glaucoma care and management on an ongoing basis, looking at progression reports for the macula, as well as the RNFL, looking at these trend analysis reports and looking at the slope for the loss of rate of change is really what's essential. And this is what is a trigger for us for identifying someone who has glaucoma and is getting worse, or a normal individual who, as the question was posed to me just earlier, is normal at one point and then progressing and getting worse at some point in the future and truly having disease. So you can do it with RNFL thickness profiles. This report helps you out with just a descriptive value, the test-to-test comparison. This is sort of that answer where I was, answering 5 to 8 microns between tests. So if you want to, get the slide here, this answers my question. This is the answer to the question that I just answered.
Mike, there's a really good question in here that just came in. How long after initiating or changing therapy due to progression do you consider further progression to be caused by pre-therapeutic change damage?
That's a good question because that's a really hard one to answer. Mm-hmm. After initiating therapy, change from pre-progression to current, I don't know that we can decipher that at any point in time. The answer to that question is to go back, look at your risk factors, look at your target pressure, or look at your pre-treatment IOP, look at your target pressure that you've estimated 30%, 35%, 40% decrease in IOP from pre-treatment baseline based upon your risk factors. And don't worry about if it's come from before treatment or more recently with treatment. That doesn't matter. If you're not at your target pressure, step up the therapy. And so one of our final slides here is, RNFL age-related thickness, which we talked about earlier on in tonight's lecture.
Mm-hmm. Yeah,
and again, it's just more of a general concept here to keep in the back of your mind with these progression reports on OCTs.
But I certainly understand the genesis of the previous question, because as I've always said, these eyes have a certain pathological momentum or physiologic inertia. And when we do something, it just doesn't stop on a dime, so to speak. So I guess the issue would be, or for me, I mean, probably within 3 to 4 to 6 months, because once we intervene in glaucoma, we usually really slow it down. So I think anything that happens in that first 6 months after you make that change probably is a pathological momentum. And another question, Mike, do you ever recommend obtaining 2 baseline on the same day? If not, what is your time frame?
No, that's a pretty decent way to cheat the system a little bit, is to take 2 OCT scans on the same day. I mean, you have to keep in mind that then your baselines are consolidated to a single day, but it does allow you to cheat the system and to get progression analysis a little bit more quickly on. I think the take-home point is that certainly we need a series of visual fields up front for our glaucoma patients, as much as 2 per year early on. OCT, generally more along the lines of once every 12 months. But, the rate of progression the identification of slow progressors versus fast progressors is only going to come about with some amount of time. And, so making sure you're doing the test is a key thing. So here's an example of progression on the Cirrus report. Here's some of the highlights there. There's event analysis in the thickness map, trend line analysis down at the bottom right. Here's just another example of what you see when there's inferior temporal loss of retinal neurofiber layer that wasn't there on the 2 baselines. Again, generally I say my baselines are often 9 months to 12 months from the time of diagnosis is usually the follow-up.
And I think our final question here, Mike, is when utilizing GPA, when do you recommend resetting baseline?
So for visual fields or for OCT? I mean, I
think both.
do that. Yeah, both. Being able to change the baseline is an important tool to have. More importantly, you need to make sure that in your progression analysis, and this goes for Spectralis, for TopCon, for OptiView, because they all do some form of serial analysis. They don't do quite the same progression analysis that the Zeiss does, but all the instruments do some form of serial analysis. You have to get rid of the bad data. So any bad visual field, bad OCT scan, you can't let it confound your data analysis. Changing the baseline, in long-term patients, 10 years or so, who undergo a trabeculectomy, a tube shunt, other significant changes, that's when I look towards changing the baseline. Or with the Zeiss instrument, I can actually do dual baselines. But I think the more important concept, as you're looking for change over time, looking at these reports, looking at progression analysis on a visual field, it's more important to make sure that all your data is accurate and reliable so that the instrument can do its job, just as you said earlier, Joe, so that you can do your job more efficiently, more effectively, and more accurately.
So I think, Mike, it's about time to wrap up. Is there anything you want to say finally in your presentation to bring it on home?
I think that's it. I did my wrap up there.
Well, that is fantastic, Mike. I'm going to ask you to stop sharing your screen.
Okey doke. Hold on, it's over here. Come on, screen share. I've toggled it into a tiny window, so give me a moment here, Joe. What the heck is going on?
Can you see mine now, or do you just see yours?
I just, what the heck? Oh, I know. It's over on my laptop monitor. Off to the side.
All right, I'll share.
All right.
I will share my screen again.
I'm out.
I gotta say thank you so much. That was fantastic. It was a great presentation. You know, Mike, I certainly appreciate you indulging me and allowing me to interrupt
Oh,
occasionally.
I wouldn't do it without you, Joe.
And for me, this is like sitting in a room just having a conversation with you. I mean, it just flows so smoothly. And I find that many of our speakers, you're one that you really engage my interest. And you and I have worked together in lots of presentations live and panels. And I've been on panels, and I've been in multi-presenter forums where it's like going to the dentist. But when I'm working with you, it's like a day off. It is just so easy. So thank you so much. I thought that was a fantastic presentation for us.
I enjoy it every time, Joe. Thanks to you and your group, and to Greg and everybody. I look forward to seeing you guys all sometime in 2022.
Absolutely.
Take
You'll
care.
you'll be on several of our live presentations as well, live and in
Thank
person. So upcoming December 12th, next Sunday, we have a twofer. We have morning and night. We have pediatric eye exam for the primary care optometrist. This was repeatedly requested. So we have Dr. Nidhi Rana from Will's Eye doing that presentation. And Dr. Katie Grainer is going to do what's wrong with that cornea and can scleral lenses help. We have 11 a.m. Eastern time and 7 p.m. Eastern time next Sunday. Upcoming ocular oncology, what every optometrist needs to know, when the top ocular oncologist in the country or even in the world, Dr. Tim Murray, formerly at Bascom Palmer Eye Institute, now at Murray Retina. And I've heard him lecture before, and he's really fantastic. A Life Without Blebs, Dr. Nenita Brown, talking about glaucoma surgery as a glaucoma specialist. She will be on Sunday, the 19th in the evening. Dr. Chris Putnam, who is serving our country overseas, will join us for off-label meds with clinical optometric implications. And we're going to wrap up Monday, December 20th with myself, Mark Dunbar, and Greg Caldwell, Glaucoma Clinical Case Conversations, a series of cases where we will just dissect it and give us our input. Now, for 2022, COPE is going to no longer allow webinars to be counted as live education, but there will be distance-based learning available. This will vary by state, and it'll be very important to ascertain what is allowed by your individual state, but we will continue doing some webinars in 2022 under distance-based learning. We have live events. Our next one is in Scottsdale, Arizona, at a new venue, the Westin Kierland, a fantastic place. We're going to be going to Strasbourg, France, with our academic partner, Rosenberg School of Optometry at the Hilton Strasbourg. We come back to Florida in Orlando, June, for our Sunshine State Summer Conference. Mackinac Island meeting in August. Now this year it sold out. We couldn't accommodate everybody. We're trying to get more space, and hopefully please register early if you're interested. It's a very unique place. No cars on the hotel, on the entire island. Nashville is a Music City Fall Classic. We just wrapped that up, and we're hoping to get back across the border to Quebec City, if not in 22, then hopefully 23. You'll be getting a survey. Please take that survey and return it, because it helps us with COPE compliance. So with that, thanks, everybody. I do thank again Dr. Michael Shiglazian for his presentation. Enjoy this holiday season. Take care and be well, everybody. Have a good night.